So we move on to our next oral paper presentation. For that, I invite Dr. Anurag Bajpai. He is a consultant pediatric endocrinology associate director at Regency Center for Diabetes, Endocrinology and Research, Kanpur, with special areas of interest being obesity, diabetes, and pubertal disorders. And the second is Dr. Anang Giri. He is working at University Sebelus Haret, Sukarta, Indonesia. His areas of interest being growth and diabetes. Welcome, sir. So for next we have oral presentation. So we will be giving 10 minutes time for each session for each presenter, 8 minutes for presentation and 2 minutes for question and answer session. At 6 minutes there will be a bell and you finish off by there will be buzzer. So for first I'm calling Dr. Vedita.
Good afternoon, everyone. I'm Dr. Vedita from Indira Gandhi Institute of Child Health, mentored by Dr. Vani and Dr. Raghupati sir, here to present my study, the clinical, etiological, and the laboratory profile of 46 XY disorders of sexual development from a tertiary care center in South India. The disorders of sexual development is a group of clinical conditions where the anatomical, gonadal, or the chromosomal sex is atypical. 46 XY disorders are further subcategorized into disorders of gonadal development, disorders of androgen synthesis or androgen action, and persistent Mullerian duct syndrome. 46 XY disorders covers a wide spectrum of phenotypes which could range from unambiguous female genitalia to ambiguous male genitalia. So, since as we see that the phenotype can vary, it emphasizes the need for comprehensive evaluation with a multidisciplinary approach. So, identifying an underlying cause would help us anticipate any immediate or long-term health concerns. Thereby, with an objective to study the clinical, laboratory, and the etiological profile of cases, especially with the 46 XY disorders, with a secondary objective to study the molecular diagnosis in the selected group of patients. It was a hospital-based observational study with children with DSD diagnosed and managed over a period of 10 years from Jan 2013 to December 2023, conducted at the endocrine department, with the study population being all the cases less than 18 years presenting with complaints of either atypical genitalia with or without palpable gonads, hypospadias, undescended testes, female genitalia with primary amenorrhea, or an apparent female genitalia with clitoromegaly, posterior labial fusion with inguinal or labial mass, but with 46 XY karyotype. We had a total of 120 which were screened, but however, because of the incomplete data or unclear etiology and the unclassified disorders, few were excluded. So around 66 patients totally met the inclusion criteria and their data were retrieved into the study. So the data reviewed included the clinical details as well as the laboratory evaluation, which was guided only by the clinical features like the hormonal assay, the HCG stim test, and ultrasound pelvis, and the genetic workup in the financially affordable cases. So based on the clinical features and the laboratory evaluation, few of those which were considered were the high gonadotropins with low testo and a biopsy proven for gonadal dysgenesis, and asymmetrical genitalia, as well as the histopathological examination for an ovotesticular DSD, and based on the HCG stim test, a T by A value of less than 0.8 for 17 beta HSD deficiency, and a T DHT value of more than 20 for 5 alpha reductase deficiency, and red has females with breast development, normal to high testo, and DHT for complete androgen insensitivity syndrome, and the presence of atypical genitalia with high basal LH, FSH, high testo during mini puberty, or later with a normal HCG response with normal gonadotropins for a partial androgen insensitivity syndrome, along with the other classes of CH, which could include 3 beta and 17 alpha HSD deficiencies. So a total of 66 patients who were included. It was seen that the age of presentation varied from neonatal to 18 years, with 59% presenting during infancy. Like we can see this in the table, 27.3% presented between an age group of 1 to 6 months. However, majority of 71.2% were assigned a male gender at birth, with the rest 28.8% assigned a female gender at birth. The 6 female assigned babies were, however, reared as males before they were presented to us. So the presenting complaint, majority of them, 97% presented with atypical genitalia, 42.4% with hypospadias, and 30.3% with micropenis, and 28.8% with undescended testes. Consanguinity was observed in 40.9%. Before we move on to the specific characteristics of each of them, the final etiology which was seen in that a total of 66 patients who were enrolled, 50 were because of the 5-alpha reductase deficiency, the next most common being the androgen insensitivity syndrome with a partial of 22.7 and a complete of 10.6, with other androgen biosynthesis defect amounting to 9.1%, and ovotesticular DSD with 4.5% and 3.1%, that is 2 cases of complete gonadal dysgenesis. Here, highlighting only few of the baseline important characteristics in each of the cohorts, what we observed was that in the 5-alpha reductase cohort, 60.6% presented with a spheno-scrotal urethral opening with a mean EGS of 7.03, and in the PAIS cohort, we had seen a similar penoscrotal hypospadias with a mean EGS of 6.83. Some of the biochemical parameters in the 5-alpha cohort was a mean TDHT value of 50.3 and elevated DHT and testo in the PAIS. We had a total of 7 cases of CAIS with a mean EGS of 3.43 with elevated testo and DHT, and among the ovotesticular and the gonadal dysgenesis were the presenting complaints with the low testo in both the basal as well as the stimulated and the complete gonadal dysgenesis. A total of 22 patients had underwent genetic screening. Among them, 45.4% were positive for the SRD5A2 mutations, which amounted for 45.4%, but none of the AR gene mutations turned out to be positive. Here, highlighting few of the Indian studies to correlate the same. A study done by Das et al., which included 48 subjects, had a result similar to that of our study, where the majority was because of the 5-alpha reductase and 35.4%, followed by androgen insensitivity syndrome. However, in the other studies, it was either the disorders of the gonadal development or the androgen insensitivity has the most common cause. Concluding my study that 46XY disorders is a heterogeneous group with wide spectrum of clinical presentation, thereby elucidating the exact cause is especially challenging and requires a stepwise approach. Early identification and treatment helps to anticipate the long-term complication, including fertility and the psychosocial development, and thereby a multidisciplinary team is needed for effective management and improved quality of life. These were my references, and thank you. This is my team.
So very good presentation and very challenging condition to diagnose. You mentioned that none of the mutations were positive for androgen insensitivity. So was it you were doing a whole genome sequencing or an exome sequencing?
Sir, the whole exome sequencing.
Whole
sir.
exome, because a lot of the problems in AIS is actually in the androgen receptor is in the promoter region. So that might be missed, and that can explain maybe a few factors. Just one more point before we open to the audience. Regarding the classification of AIS versus 5-alpha, did you find any genetic switches there? Like your clinical diagnosis and genetic diagnosis, was it varying?
Yes, sir. They did vary. In one of the case, we had initially thought it to be a PAIS, but it turned out to be a SRD5A2 mutation, and that is when we took it under the other cohort, sir.
So I think that is an important factor. Maybe a few questions from the audience. You like to?
Based on your experience, how to diagnose, especially a laboratory profile in children more than 3 months? Do you perform all with 46XY with stimulation?
Sorry, sir, I didn't get your
stimulation test.
Sir, if it is around the mini puberty, we do not do it. But if it is pre-pubertal, we usually go ahead and do the HCG stim test, and based on the values, we classify them, sir. Thank you.
Thank you.
If there are no more questions, we will thank you once again for a wonderful presentation.
Thank you, sir.
Yeah.
Thank you, everyone.
Thank you, Dr. Vedika. I would like to call upon Dr. Shruti Monkar from India for her oral presentation.
Good afternoon. My topic is device usage characteristics and glycemic control in Indian adolescents with type 1 diabetes using the Minimed 780G system. Without technology, there are certain hurdles in the management of type 1 diabetes. The use of HbA1c as a standalone test for assessing glycemic control is a bit of an oversimplification because it does not account for glycemic variability and its associated complications. The achievement of ISPAT glycemic targets requires rigorous control, but this often occurs at the cost of increased and more severe hypoglycemic episodes because basal rate modification is not possible with long-acting insulin injections. The advent of technology has revolutionized the management of type 1 diabetes, particularly advanced hybrid closed-loop systems like the Minimed 780G, which is available in India. This is essentially an insulin pump with an inbuilt predictive algorithm which receives input from the CGM sensor and modulates insulin delivery accordingly. It has certain special features. The SmartGuard technology, which has an autobasal function which regulates the basal insulin rate in response to real-time sensor glucose, using the PID algorithm, that's the proportional integral derivative. That is, it assesses how far the sensor glucose is from the target, how long it has been away, and the rate of change of glucose. It also has the autocorrection feature, which delivers automatic boluses in case a patient misses the dose or has put in wrong carbohydrates. And in order to prevent hypoglycemia, it has the safe meal bolus, which, depending on the CGM slope and the insulin on board, it reduces the food bolus if hypoglycemia is expected. All these features aim to achieve a higher time in range with a less severe risk of hypoglycemia, reduced glycemic variability, and thereby reduced complications. The conventional metric as per international census guidelines is the time in range, which is 70 to 180 milligram per deciliter. However, there is an emerging concept of the use of a newer metric, that is time in tight range between 70 to 140 milligram per deciliter, because this range is similar to the normoglycemia range in healthy individuals. As per now, there are no consensus guidelines on what the cutoff for the time in tight range should be. Certain studies have mentioned 50 up to 62. For preschoolers, ISPAT recommends more than 50% time in tight range, and this corresponds to an HbA1c of 6.5%. Thus, we planned a study with the objective of assessing device usage characteristics and glycemic control in Indian adolescents with type 1 diabetes using the 780G. This was a single-center observational study which included patients with confirmed type 1 diabetes on the 780G for at least 6 months. Those with uncontrolled disorders or on concomitant medications affecting glycemic control were excluded. Sensor and pump usage data on 12 children were analyzed retrospectively, and the parameters written in the table were assessed. Most of the patients belong to the age group of 10 to 14 years at onset of pump initiation, and the mean pump usage duration was 12 months, ranging from 6 to 24 months. The mean sensor usage time per day was 78%, ranging from as low as 45 to as high as 96%. The parameters highlighted in red are the ones where ISPAT targets were met. The mean time in range observed in our patients was 71%, ranging from 52 to 88, with a time in tight range of 48%, ranging from 30 to 63. The achievement of these targets was also associated with an increase in the time. The time below range targets were also met. So it was not at the cost of an increase in the time below range. And the coefficient of variation was also within the levels recommended by the ISPAT targets. This is a slightly busy table which describes individual patient CGM metrics. But if we go by the color coding, the ones with green are where most of the ISPAT targets are achieved, whereas the red ones are the ones with poor glycemic control. What differentiates these two is the percentage of sensor and auto mode use. It was above 85% for those with good glycemic control and below 50% for those with poor control. Similarly, the number of patient-initiated boluses was much higher in those with good control. So essentially, those with bad control did not use the sensor for too long, did not use the auto mode, and also underdosed on the boluses. The mean auto mode usage was 78% of device usage time. The mean number of patient-initiated boluses per day was 4.2. Automated insulin delivery constituted 53% of the total daily dose of insulin, and the total daily autocorrection dose was 15% of the total daily dose. 5 users used optimal settings, that is the basal target glucose of 100 and an active insulin time of 2 hours, And the time in range and time in tight range among these patients was impressive, that is 81.2% and 57% respectively. This graph compares CGM metrics at 3 monthly intervals. If we see the dark green bands, that is the time in tight range, that is steadily improved from 47.3% during the first 90 days to 59.5% during the fifth 90 days. There was also a progressive improvement in the overall time in range from 70% to 81.8% without any increase in the time below range. There was steady improvement in sensor usage from 79% to 83% and a steady decrease in the average sensor glucose and in the SD of sensor glucose. Regarding the achievement of SPAD targets, all targets were met in 6 out of 12 patients. The time in range target was met in 58% patients, and the time below range targets were met in most patients. Those who met SPAD targets had a significantly higher usage of sensor and auto mode usage, 89% and 92% versus 67 and 63 in those who did not meet targets. This is a comparison of our study with other similar studies. Though our sample size is much smaller compared to these, but if we see the time in range, time in tight range, and the time below range are consistently similar, which means that the pump shows consistent findings across ethnicities. Similar with the coefficient of variation. Thus, to conclude, there was a steady increase in time in range and time in tight range and a reduction in time above range in 780G users without increased chances of hypoglycemia. We observed consistent results and progressive improvement in CGM parameters over time with pump usage. There was a reduction in glycemic variability as evidenced from this SD and this coefficient of variation of mean sensor glucose. And increased duration of sensor and auto mode usage translated into better CGM outcomes. Thank you.
Any question from the audience?
Do you think changing range from 70 to 180 to 70 to 140 will reflect in better glycolated hemoglobin?
Yes, it will, because there are studies which have shown that when there is an increase, there is an improvement in the time in range. This improvement usually occurs more in the 70 to 140 range than in the 140 to 180 range. So there will be an improvement.
Thank you.
And I think the root point also is that probably HbA1c is not the end of the story. Time in range itself is such a good parameter that maybe on long term, based upon the DCCT data, when they converted that into time in range, it may have been a better predictor maybe than HbA1c than many of these long term complications. So I think even if your time in range is coming down, your HbA1c will of course come down, but otherwise itself it's a good metric on that. One point which you did mention, after every 90 days there seemed to be an improvement. So was it because that you were reinforcing in terms of their education, or is it that those who had a good outcome were followed up for a longer time?
So I think it's a bit of both. So those who had a good outcome, of course, had better follow-ups. But I think it's also to do with the learning by the pump.
Yeah.
Because
and overall, how many numbers would have been there by around the end of the study? 450 days roughly?
There were, so this data, so everybody had data for at least
6 months, 180 days. Beyond that, so
beyond that, I think 3 patients did not have data till 15 months. The rest had it.
Okay.
Yeah.
Dr. Shruti, one last question. So I want to understand, like, what were the characteristics of those patients that were in tight range control? Like, were they having more of the user-initiated meal boluses?
Yes, so they had much more sensor usage, auto mode usage, and the patient-initiated boluses.
So these were specifically for those that were in tight range as well?
Yes.
Yeah. Okay. All right. Thank you so much.
Thank
I
you.
would like to invite Dr. Nimisha Dange for her oral presentation.
Good afternoon, everybody. I'm Dr. Nimisha Dange from Pune, India. I would be presenting a study titled Patterns and Determinants of Serum Amylase Lipase Concentrations in Indian Adolescents and Youth with Type 1 Diabetes. Islet acinar cell axis plays a major role in the relationship between exocrine and endocrine functions of the pancreas. The paracrine role of insulin is well known on other pancreatic enzyme actions. Exocrine pancreatic insufficiency has been documented in individuals with type 1 diabetes. Impaired secretion of both amylase and lipase established in relation with impaired fasting glucose, obesity, and metabolic syndrome. Serum lipase has been proven earlier as a biomarker for staging of pre-type 1 diabetes. Amylase insufficiency observed in association with metabolic risk. As puberty is a state of increased metabolism and insulin resistance, it significantly influences the progression of type 1 diabetes. However, the impact of puberty on amylase and lipase concentrations has not been reported previously, and there is a paucity of data on pancreatic enzymes in Indian adolescents with type 1 diabetes. Therefore, we hypothesized that there is a remarkable pattern of pancreatic enzyme during pubertal years in adolescents with long-term diabetes affected by glycemic control. Metabolic risk could affect pancreatic amylase and lipase secretion. Therefore, the objectives of the current study are to characterize and predict determinants of amylase and lipase concentrations in adolescents and youth with diabetes, to assess the relationship between serum amylase, lipase, and the prevalence of metabolic risk. This was a cross-sectional observational study. Children presenting to our type 1 diabetes OPD were invited to participate in this study with confirmed diagnosis in the age group of 10 to 18 years with disease duration for more than 1 year. Children with multisystemic involvement, those on statin therapy to treat dyslipidemia, and on pancreatic enzyme replacement therapy were excluded. The final analysis was performed on 291 adolescents. History, clinical examination, and anthropometry were noted. Lab investigations were performed. Body composition was measured using bioimpedance analysis. The criteria of raised fasting glucose was not applicable in the setting of diabetes to define metabolic syndrome as per the definition of IDF 2017. Therefore, either the presence of abdominal obesity, elevated triglycerides, low HDL, or high blood pressure were taken as the presence of metabolic risk as cited in the literature previously. The mean age of the study population was around 15 years. With mean disease duration of around 7 years, the entire cohort was on basal bolus regimen of the insulin with average dose of 1 unit per kg per day with average A1C of 10%. The median amylase concentration of the population was around 62 units per liter, while median lipase concentration was around 35 to 38 units per liter. Around 70% children had long-term disease, while around 47% children had poor glycemic control with A1C more than 9.5%. On performing sexual maturity rating, around 66% children were nearing to the completion of their puberty. Participants with above goal glycemic control had 34% higher risk of having low amylase concentrations, while 42% higher risk of having high lipase concentrations. This graph here depicts the trend of serum amylase and lipase during pubertal years. On the left side, serum amylase concentration is seen to be decreasing as the puberty progresses. The red bars indicate children with poor glycemic control, while serum lipase concentrations are increasing as the puberty progresses. Children with excessive weight gain had significantly higher lipase concentrations. Amylase and lipase concentrations were similar in the categories of fat percentage Z-score. The graph here shows the distribution across fat mass Z-score of both the pancreatic enzymes. The red dot represent serum lipase concentration, while blue dot represents serum amylase concentration. Serum amylase was distributed from 30 to 100 units per liter, while lipase was distributed from 10 to 60 units per liter. Around 49% children had one or more than one metabolic risk in our study population, and there was no remarkable pattern of amylase and lipase in adolescents with metabolic risk. The multiple linear regression was performed to predict the determinants of serum amylase along with demographic and disease parameters TSH, vitamin D, and serum calcium were also taken as independent variables, and there was no significant predictor seen for serum amylase, while low serum calcium and TSH concentrations significantly predicted the serum lipase concentrations. To summarize, puberty and poor glycemic control imposed risk of lower amylase and higher lipase concentrations, while pancreatic enzymes did not exhibit any particular pattern in relation to fat percentiles or metabolic risk. Higher lipase concentrations were found in participants with higher BMI. Lipase concentrations were affected by concentrations of TSH and serum calcium. This was the first study in Indian adolescents with type 1 diabetes highlighting pattern of pancreatic enzymes, and speculation of pubertal physiology in relation to that was evaluated for the first time. However, more sensitive fecal elastase test is needed for the diagnosis of exocrine pancreatic insufficiency, and the overall glycemic control was poor of the study population, and we need healthy controls for better interpretation of results. To conclude, when evaluating children and adolescents with long-term diabetes, attention should be given to exocrine pancreatic health. Improvement in glycemic control and preventing excessive weight gain can affect exocrine pancreatic health positively. To achieve optimal pancreatic health in individuals with diabetes, appropriate thyroid function and metabolic and calcium metabolism are needed. We cater our services to over 600 children with type 1 diabetes with holistic approach. And this one kid who is on the regular follow-up of diabetes is enjoying her time with our medical clown. Thank you.
Can I ask you about the TSH? Can you explain why it's the one of the determinant for the lipase?
Could you please...
TSH. You mentioned that their thyroid function is also one determinant for pancreatic enzyme. Can you explain?
How does thyroid affect the pancreas?
Yes.
The raised thyroid TSH concentrations were significantly predicting the lipase concentrations in our children.
Biological mechanism, that's what.
No, I could not find it in literature.
Because in hypothyroidism, we do not see that many because severe. So this is just like maybe a finding that we have observed. What are the implications of this study from a practice perspective? One, and number two, all of these patients were type 1 proven in terms of autoimmunity, or there might have been some subtle pancreatic disorders going on as well.
The answer to the first question, we see a lot of children with long-term diabetes duration. As you have seen, the mean disease duration was around 7 years, and lot of time they present with vague complaints like indigestion, bloating, gaseous distension, which is not related to their glycemic control when we go through the self-monitoring of blood glucose or A1C at that point of time. Therefore, we speculated pancreatic enzymes would have some role to play. And
this level, do you think, can explain that? The sort of level of variation you found, could it really translate into a clinical presentation? Because this looks like not a huge difference per se on that.
Yes.
And about the secondary diabetes, were you sure that they were all type 1 and not secondary?
So children who afford the testing of the antibodies were performed for them. But those who could not afford, the symptoms or the clinical presentation and C-peptide levels were considered, while those who were on the diagnosed cases of the exocrine pancreatic insufficiency on PERT were excluded from the study.
And imaging was done in most?
The pancreatic imaging? No, sir.
Okay. Any questions from the audience? I think this was a very interesting angle of going the other way around from we think of exocrine causing endocrine. You're talking about endocrine causing exocrine. So this is an interesting field. Needs more confirmation and more, I think, studies about the effect of this in terms of practice. Thank you.
I just have a comment. So when we talk about self-monitoring of blood glucose, we're actually like understand on CGM. Their day-to-day variability of glucose, is that also causing those kind of symptoms? We have to explore that also before we really are able to conclude that yes, it's not that, and it's this. Like so.
There are too many issues: autonomic neuropathy, gastric
Yes,
obstruction,
agreed.
pseudo
Yes,
obstruction. So there can be so many explanations for that. So it's going to be difficult to add plausibility, clinical plausibility. But I think this is an interesting finding
Yes.
that you have found, and the way they are contrastingly going one above, one up, and one low. So this needs to be confirmed first, and then maybe go on to that.
Right. Yeah.
Thank you.
Thank you. I would like to invite Dr. Anushka Kapila from India for her oral presentation.
Good afternoon. I'd like to present my paper on adrenal insufficiency after steroid therapy in children with steroid-sensitive idiopathic nephrotic syndrome. So glucocorticoid exposure can lead to adrenal insufficiency in a significant proportion of nephrotic syndrome patients, and the prevalence that has been shown in previous studies has ranged from 35% to 63%. The need that we felt for the study was that adrenal insufficiency is underreported and often overlooked in children with nephrotic syndrome. And studies that have been done have mainly focused on steroid-dependent and resistant cases, and screening is not routine practice. So we aim to estimate the prevalence of adrenal insufficiency in children with nephrotic syndrome after completion of steroid therapy. The primary objective was to estimate the proportion of children with nephrotic syndrome who had adrenal insufficiency as defined by a serum cortisol level less than 18 micrograms per deciliter 30 minutes after a low-dose stimulation test between 4 to 12 weeks after completion of steroid therapy. The secondary objective was to estimate this proportion using an 8 AM serum cortisol level less than 5 micrograms per deciliter to study the correlation between the 8 AM levels and the serum cortisol levels after LDST, and to find out the association between adrenal insufficiency and steroid toxicity. So the study was a cross-sectional study done in a tertiary care hospital in Delhi, and institutional ethics committee approval was taken. We enrolled children between 1 to 12 years of age diagnosed with steroid-sensitive nephrotic syndrome who had completed steroid therapy and were in remission. Excluded children were steroid-sensitive, steroid-dependent and resistant cases, and those who were on any kind of steroid therapy. We used the baseline 8 AM serum cortisol cutoff of less than 5 micrograms per deciliter and a serum cortisol cutoff of less than 18 for 30 minutes after the low-dose ACTH stimulation test. These were our Sanactin vials. We had a pre-designed case recording form to record any social demographic details, clinical features of the nephrotic syndrome disease, clinical features of adrenal insufficiency, and the symptoms and signs of steroid toxicity. We had taken a prevalence of 62.5% from a previous study by Abhay Gunawardena et al., and our sample size calculated was 72. The primary outcome variable was the proportion of adrenal insufficiency calculated using the low-dose ACTH stimulation test with a cutoff of 18 microgram per deciliter, and the secondary outcome variable was the proportion using the 8 AM serum cortisol level less than 5 microgram per deciliter. So the statistical analysis was done. We tested for correlation. Parametric and non-parametric tests were used as required, and a p-value less than 0.05 was considered significant. Coming to results, we had 73 children enrolled. We did the baseline 8 AM levels and the low-dose stimulation test, and the pre-designed case record form was filled. Here I'd like to point out that in all our 73 cases, 62.5% were first episode nephrotic syndrome patients. Out of 73 children, 69.8% children had adrenal insufficiency as defined by the serum cortisol levels 30 minutes after the low-dose stimulation test, whereas 45.2% children had adrenal insufficiency as defined by the 8 AM level less than 5 micrograms per deciliter. 19 cases had serum cortisol levels at 8 AM, which were normal, but they had low serum cortisol levels after the low-dose stimulation test. Only one case had a normal serum cortisol level after LDST, but a low serum cortisol level at 8 AM. In total, 71.2% children had adrenal insufficiency. We had a strong positive correlation between the serum cortisol level after the low-dose stimulation test and the 8 AM cortisol level, which was statistically significant. When we measured the 8 AM baseline cortisol levels, we saw that they were significantly lower in patients with Cushingoid facies, buffalo hump, hirsutism, and striae as compared to those patients who did not have these signs. This is shown in this box whisker plot, where you can see that the 8 AM level is significantly lower in a patient with Cushingoid facies. Similarly, for serum cortisol levels after LDST, we found they were significantly lower in patients with Cushingoid facies, buffalo hump, obesity, hirsutism, and striae as compared to those children who did not have these features, as shown in this diagram, where you can see that serum cortisol level is significantly lower after LDST in patients with Cushingoid facies. When we compared the clinical features of steroid toxicity in patients with and without adrenal insufficiency, we found that patients with adrenal insufficiency had a significantly increased prevalence of Cushingoid facies. So we calculated the odds ratio and found that patients with Cushingoid facies have 4.5 times greater odds of also having adrenal insufficiency. These were the clinical features of adrenal insufficiency that we found in our patients. And 13.7% patients had symptomatic adrenal insufficiency, whereas 57.5% had asymptomatic adrenal insufficiency, and fatigue was the most common symptom which we found. The cumulative steroid dose was highest received in the children with symptomatic adrenal insufficiency. When we followed up these patients, we found that out of 52 patients who had adrenal insufficiency, 50% of them experienced relapses on follow-up, whereas in those without adrenal insufficiency, only 15% experienced relapses. So we calculated the total number of relapses since the onset of their disease and found that patients with adrenal insufficiency had experienced a significantly higher number of total relapses. We found no significant difference between the sodium, potassium, calcium, and sugar levels between those with and without adrenal insufficiency. So when we explored the literature, we found that the 1 microgram low-dose ACTH stimulation test has been suggested by some studies to replace the standard dose in glucocorticoid-induced adrenal insufficiency. And there have been studies which also have shown an excellent correlation between basal cortisol levels and cortisol levels after 30 minutes of the low-dose stimulation test, similar to our study. When exploring the importance of the morning serum cortisol test, we find that it can very reliably exclude adrenal insufficiency, but it is difficult to point out or diagnose adrenal insufficiency based on the singular test. The recently published European Society of Endocrinology guidelines for glucocorticoid-induced adrenal insufficiency recommend assuming adrenal insufficiency in patients with a history of glucocorticoid treatment who are now presenting with an exogenous Cushingoid syndrome. So when we explored the guidelines on nephrotic syndrome, we found only one guideline which vaguely advises prednisolone during intercurrent illnesses, but there is no guideline on screening, treating, and managing these patients. The strength of the study was that we used a low-dose stimulation test, which is more sensitive for glucocorticoid-induced adrenal insufficiency, and many of our patients were first episode nephrotic syndrome patients. However, all our patients could not be tested at a consistent time period following cessation of glucocorticoid therapy, and 4 to 12 weeks is a long duration. Our study population was heterogeneous, and significant association between cumulative steroid dose and adrenal insufficiency could not be found, which possibly could be due to patients taking a lot of steroids from unlicensed sources in our country. Conclusion, 71.2% adrenal insufficiency was found. There was strong positive correlation between the serum cortisol at 8 a.m. and serum cortisol after low-dose stimulation test. And patients with Cushingoid facies and those who had experienced more relapses were more likely to have adrenal insufficiency. So we recommend that children with history of glucocorticoid use should be assessed for clinical features of adrenal insufficiency, and parents should be educated and well informed of this condition. Baseline serum cortisol level should be done, and if it is normal, but a high index of adrenal insufficiency is still persisting, you should then continue to do a low-dose stimulation test. Further research is required for long-term follow-up to find out whether these patients go into adrenal crisis and for how long this glucocorticoid-induced adrenal insufficiency persists. And more extensive studies need to be done to estimate a correct cortisol cutoff value, because most studies for this cutoff have been done on normal patients rather than patients who have adrenal insufficiency. Thank you.
I think a very good study in highlighting a very important point. All of us know that there is a sort of a exogenous HPA suppression which is there and which may last from 6 months to 12 months. So generally, we will be giving them stress dosing in the first 1 year.
Yeah.
Now, the main question would be that if you have proven that they have low baseline cortisol, whether you start thinking of replacing them with hydrocortisone, that will be an important question. So what are your views on that?
So in May 2024, there was a guideline published on glucocorticoid-induced adrenal insufficiency by the European Society.
Yeah.
So they suggest that if morning cortisol is less than 10, not even less than 5, it's less than 10 or 5 to 10, you go on with the physiological dosing, and you can measure it again 3 months later. You don't essentially have to. They don't recommend doing a simulation, ACTH simulation test.
Because I think we would not probably be thinking of treating everybody who has a low stimulated cortisol, but low baseline cortisol.
Yes.
And what was the lowest level you're talking about in terms of the baseline? What was the lowest you found?
So 0.5.
0.5, very, very low. So I think
very
we
low.
see so many exogenous, Ayurvedic, homeopathic, so many patients taking those medications.
Yes.
Their cortisol is low, we have to treat them. I think that's a very important point. If you have a low baseline cortisol on, even if they are off steroids, so 4 weeks is a good enough time. You should have washed out, requires treatment. Yes, Dr. Sanjay.
What pathophysiology in your mind led you to fix the duration 4 to 12, between 4 to 12 weeks after completion of therapy?
So, sir, in nephrotic syndrome treatment, the second we give 4 weeks of, at least in relapse, we give 4 weeks of alternate day treatment. So they have been receiving alternate day steroids only for the last 4 weeks. So then I have a 4 week of also to allow some washout and to regain the
So generally
access.
HPA axis, generally we say that if you have a 6-week treatment and you give alternate for 4 weeks, it should have improved by that time, even at the end of it. So giving a 4 week is a very good time, I think, to allow the axis to recover, because for the first hypothesis is that you're given alternate day, it should not have happened.
It should not have happened.
By not down, but I think this is a very valid point. So whether it's inhaled steroids, whether you have this sort of alternative steroids.
Is there any potential chance of adrenal insufficiency, adrenal crisis during the 4 week period?
Sir,
If you stop
sir,
and do the test after 1 month.
Yes,
4
sir.
weeks. Is there no any?
See, none of the patients actually had a crisis. So it's very unlikely that they will develop a crisis. It's only a ACTH deficiency, so electrolytes will be normal. You may have mild hyponatremia, you may have lethargy, weakness, maybe hypoglycemia due to illness, but because your potassium aldosterone is normal, they will not go into that frying crisis. That is the advantage, probably, at least from a clinical perspective in this scenario. So I think if you do it before 4 weeks, the number will be 100%.
100%.
Everybody will be insufficient. Then the whole purpose of the study is there. I would probably say we should push to around 12 weeks and beyond. That will give you a better picture.
But is there any chance or not?
Yes.
Adrenal
If they have so you have to give a guideline. If you are having a sick day, you have to give stress dose of steroids irrespective of your results.
Yeah.
So in the first year, so that will, I think, take care of it. It's very unlikely that they will spontaneously go into crisis. But yes, if they have fever and you don't give them steroid, they will. So this becomes important.
Because adrenal insufficiency has very non-specific symptoms, but it can be life-threatening. So it's important to have a low threshold for diagnosis.
I think we'll close it here for the purpose of.
Is there any pain for hydrocortisone pain available in India or not?
We've got the syringe and the vial, you can use it. It's the same thing. Rather than the pen, you got the syringe and that available. So we give it to every patient. Thanks a lot for a wonderful study and presentation.
Yes, thank you, Dr. Anushka. I would like to invite Dr. Alappan Mahapatra for his presentation from India.
Good afternoon, everyone. Thank you, APES 2024 and SPF for giving me this opportunity to present my research work in front of you. So why we felt the need to develop a mobile application in the era of a clinical diagnosis? So the answer lies in the following case. A 16-year-old boy presented to us with features of hyperglycemia as well as high blood glucose level. The child was diagnosed as type 2 diabetes based on few features like acanthosis was present. He was a type 2 diabetic in his family and his BMI was more than 27. And he was prescribed as metformin by some physician. Later on, after 3 months, he presented to us with features of diabetic ketoacidosis. So ISPAT 2022 guidelines has clearly mentioned if the features of hyperglycemia with osmotic symptoms, if there is islets and antibodies are negative, then only we can think about the type 2 diabetes. In this patient, the GAD was positive and this is a misdiagnosis of a type 2 diabetes labeled as type 1 diabetes labeled as type 2 diagnosis. So the proper classification of childhood diabetes is very important and often misdiagnosis of type 1 diabetes as type 2 may lead to fatal consequences like diabetic ketoacidosis. Not only that, for the proper classification, we need some costly studies like autoimmunity screening, genetic studies. Also, there was lack of specialists right now in our country present. So there are often misdiagnosis, unnecessary workups are there, and there was delayed referral. The available resources right now in our hand are some algorithms, some textbooks, and some guidelines which are very complicated and time consuming, and it is very difficult to implement it in a busy pediatric practices. So we felt the need and we developed multiple point of care tools in terms of growth, in terms of bone age, puberty and obesity. With this aim, we have a plan to develop a point of care tool which will be a comprehensive, integrated one and should give us instantaneous guidance for development. With this aim, we develop and validate diabetes interpreter application, a mobile care tool for a point of care guidance for classifying pediatric diabetes. Our tool was based on the ISPAD 2022 guidelines as well as some local modification, and it is available in iOS and Android. This is the algorithm based on which our tool is developed. In greater than 1 year of age, if the insulin requirement is more than 0.5 after 12 months of diagnosis, we do not recommend to do any costly investigations in terms of autoimmunity like GAD, insulin antibodies or like that, and we straightly diagnose them as case of type 1 diabetes. This is the landing page of our diabetes interpreter, and you can see based on these minimal inputs, date of birth, date at diagnosis, date at visit, anthropometry, decay at presentation or not, and total insulin dose, we can classify the diabetes as well as recommend for the further treatment. So it will be a very helpful thing in cases of a poor resource limited countries like India. So moving on to our previous case that we have been discussed and see what our application give. This is a male child with date of birth, everything was given, height and weight, and the total insulin dose was minimal, and you can see the app is recommending GAD antibody before labeling this child as type 2 diabetes. So by using this app, probably we could have misdiagnosed the case as type 2 rather than type 1. So we started our validation and having 302 subjects that has presented in our pediatric OPD clinic, and from the duration of January 2018 to 2023, the proportion of type 1 diabetes was 250, 35 was type 2 diabetes, 6 and 11 cases was respectively MODY and neonatal diabetes. There are two groups of people. One is expert who are pediatric endocrinologist, adult endocrinologist, and a non-expert group of pediatric trainee and pediatrician. The gold standard was a 24 years experienced pediatric endocrinologist in our department having his clinical diagnosis and management. So we sent a Google questionnaire based form for the classification as well as the recommendation, and each correct answer was given 1 point to that. We have classified our discordance on the basis of major, minor and moderate, and the major discordance were if their type 1 was diagnosed as type 2, if there is missing of autoimmunity in cases of type 2 diabetes, as well as missing the genetic forms and the neonatal forms of diabetes. As you can see, the concordance score was quite high in cases of diabetes in interpreter, while it was very low in cases of pediatric trainee and the pediatrician. Not only that, the concordance score of diagnosis, also the suggestion you can show the pediatrician and the pediatric trainee has a much lower score in comparison to the application, as well as pediatric endocrinologist and adult endocrinologist. Further move on to the level of discordance, you can see the pediatrician has done much more unwarranted workups in terms of genetics, autoimmunity in comparison to the application and other experts, increasing the cost of burden in the families of type 1 diabetes. Not only that, he has missed many cases of type 1 and labeled them as type 2 diagnosis. Having a specialist of type 2, the adult endocrinologist has diagnosed very well cases of missed cases of type 2 diabetes, as well as he didn't recommend much more autoimmunity in cases of type 2 as well. So you can see the concordance score, and if by using the app, we could have prevented 96% of the unwarranted workups as well as 23% of the misdiagnosis. So by using only this app, we can not only properly classify, avoid unnecessary workups, but also can delay the referrals in terms of to the pediatric specialist endocrinologist. The limitations of our study was it was a Google questionnaire based form, that is the real life scenario was not present to the experts as well as pediatric trainees and pediatricians. There is no prediction for type 2 diabetes, secondary diabetes in our case, as we are thinking to move further on this matter, and this is a single center based study which is done in our center. So this is a point of care tool and giving an instantaneous guidance. We have validated this study, but it needs to be validated across the settings. So I would like to thank you, Dr. Anurag Bajpai sir, for his constant support. I would like to thank you, Santosh and Oleti sir, Rishi Sugla sir, and Jayati ma'am for his support. Thank you, Regency CDE. Thank you all.
Yeah, thank you. Very interesting. Can you explain in India the experience for a pediatrician or doctor to use this application? Because in our countries in Indonesia, we also have looks like this to help pediatrician or doctor to make easier. But the because of the burden of the patient, they either not use this. Can you explain in India?
Sir, our main aim is to just to do not want to replace the human clinical diagnosis with technology, or we just want to guide them on the basis of that. We felt that the pediatricians or the pediatric trainees have pediatricians and the pediatric trainees have much more errors in terms of diagnosing. If we use this app along with our clinical decision, probably it could have limit the error diagnosis in terms of that. We need to implement this in our clinic. We want to implement this in clinical practices as well, and want to see the further outcome on that.
This is web
So-
based or
This is a,
application based.
This is mobile based application.
Mobile,
Yes,
yeah.
mobile
Okay,
based.
thank you.
I have just one comment, that because initially that patient went to a wrong place, so the diagnosis got wrong, and also if the patient landed with a pediatric endocrinologist, it would not got the wrong diagnosis, right?
Yes.
So what I want to say is that this application is good, this app is good, and a lot of apps get modified and all that. So I think we have to make more awareness in not only in app, other ways also to the population of the pediatricians, that you can pick up these cases early and not confuse between, because there's a lot of confusion. Adult and always confuse type 1 and type 2. Many times it has happened. They will not do a simple C peptide. If they do it, they'll come to know. So I'm just trying to say that because a lot of people will not be having the apps and not be favorable in using the apps also.
Yes.
So I think they should, more of a sense to be given to that awareness of what can be done with us. And it's very common that type 1 be confused with type 2 and type this thing. Very common nowadays.
Yes, sir, I
I
completely
think that's a
agree.
very, very valid point regarding education. And we've been doing a lot of educational activity. The problem with Dr. Kochar is that after the session is over, everybody forgets about it. And maybe they have heard it for the first time. So we thought that besides all the online availability, videos, workshops and everything, there's something which they can carry home and then they can use it. So of course, the first thing is to get them tuned with the overall knowledge and then to go forward in that. Yeah.
It's very common. The pediatricians are so busy with their own, their all vaccination and all those things. They hardly will see the app. They will just go, okay, iska test jao. That's what is happening actually in practice. I'm not talking about what the app says, but I'm just trying to say that it's very common here. They hardly get time to even use the app even when they are busy in vaccination and other things.
Yes, sir.
I have a question. So, in this app, what is the defining point which empowers you to actually not need C-peptide or, autoantibody study? What is that pivotal point I want to know? Because what I gathered is if you have been a diabetic requiring more than 0.5 unit per kilo, is that a differentiating point?
Sir, recently ISPAT guidelines has clearly mentioned that if we have a higher requirements of insulin in more than 12 months that are beyond the honeymoon phase, we can label them as type 1. There we can do the genetic study, autoimmune screening in them, but it will increase the cost, especially in our resource poor setting. It will be a difficult thing to
because
get the autoimmune.
The reason is this, that we often encounter patients, this is a very important point, type 1 or type 2. We encounter patients who have been on insulin, especially Mixtard or now there's Ryzodeg, for months and no idea about whether it's type 1 or type 2 and basically loosely floating around, and the control is poor, abysmal. And when you check the amount of insulin per kilo per day, it's way more than 0.5.
Yeah, I think the one important point is that this is for the pre-pubertal children. So after 10 years, the algorithm automatically goes into BMI mode. And if somebody is overweight, and then it doesn't talk about insulin requirement, it does consider the possibility of thinking of type 2 right away. So less than 10 years, we are not thinking of type 2.
But then less than 10 years, what is the incidence of type 2?
Very rare.
Very rare.
Exactly.
That's why this is for type less than 10 years. So after 10, that's why I'm saying, so less than 10, we are not doing GAD unnecessarily. Beyond 10, if somebody is obese and has whatever requirement, we give a consideration for GAD at that point of time.
But there are two kinds of patients. One who comes straight to you, and there you do that and complete that, get it over with, label it. And the others is being seen somewhere else, no C-peptide done, and there, of course, for you to see why, protect your patient as well as yourself, you do the GAD test. But having said that, in your support, I will say that there are many small town labs now which have sprung up, which will give you GAD negative. So there also you have a problem.
I think we'll have another session is there. So we'll discuss on detail.
Thank you.
Thank you. Good afternoon once again. I will be presenting another study titled Prevalence of Limited Joint Mobility and its Association with Long-Term Complications in Indian Adolescents and Youth with Type 1 Diabetes. Limited joint mobility is one of the known chronic complications in type 1 diabetes, also known as diabetic cheiroarthropathy, which occurs due to deposition of advanced glycation end products around the connective tissue of the joint. It is a painless entity which often goes unnoticed, and the prevalence is wide 8 to 58%. However, on prayer sign assessment, the prevalence is 22%, and I will shortly be explaining about the prayer sign. LGM is strongly associated with vascular complications, and hence a prompt workup is warranted. Rosenblum had proposed the criteria for staging of LGM. Mild limitation involves small joints of hand, moderate limitation involves large joint, and severe limitation with restricted spine mobility or obvious hand deformity at rest. The assessment of LGM is subjective and needs precision. Restriction of not just small joints of hand but large joint and spine mobility needs to be explored in correlation with healthy population. Risk factors for LGM and its association with vascular complications need to be investigated. However, there is a paucity of data on LGM in Indian children and adolescents, and the more comprehensive assessment with the help of goniometer has not been previously reported from India. Therefore, we hypothesized that children and youth with type 1 diabetes experience restricted mobility in both small and large joints as well as in the spine. There is a significant association between limited joint mobility, growth failure, and vascular complications. Taken together, the objectives of the current study are to determine the prevalence of LGM in children and youth with diabetes, to compare joint mobility in children with diabetes and healthy controls, and to study determinants of LGM. This was an observational cross-sectional study, and children presenting to our diabetes OPD were invited to participate in this study with confirmed diagnosis in the age group 3 to 20 years with disease duration for more than 2 years. Age and gender matched controls, which were the healthy siblings of these children, were enrolled. The final analysis was performed on 395 cases and 198 controls. History, clinical examination, and anthropometry were noted. Lab investigations were performed. Positive prayer sign indicates inability to extend interphalangeal joints completely, while positive tabletop sign indicates inability to extend metacarpophalangeal joints completely. The more precise and accurate assessment with the help of goniometer was carried out by an experienced physiotherapist to assess the range of motion on passive extension of interphalangeal and metacarpophalangeal joints, wrist, elbow, ankle, and lateral flexion of the spine. The mean age of the study population was around 14 years with mean disease duration of around 7.5 years. The entire study population was on basal bolus regimen with total daily dose of around 1.2 units per kg per day with mean HbA1c of around 10%. Around 72% children had long-term disease, while around 54% children had poor glycemic control with HbA1c of more than 9.5%. On performing sexual maturity rating by Tanner staging, around 46% males and 56% females were nearing to the completion of their puberty. The prevalence of LGM on screening was 9%, but this prevalence was almost doubled on goniometric assessment with 12% in moderate limitation, 5% in mild, and 1% with severe limitation. After involvement of interphalangeal joints, large joints were more commonly involved in our study population. The yellow line here represents the cumulative percentage. On comparison with healthy controls, children with diabetes had significantly restricted interphalangeal joints, metacarpophalangeal joints, large joint, and spine mobility. 14% children were short, 20 and 29% children had elevated BP and microalbuminuria respectively. Around 75% were dyslipidemic, while 58% children had metabolic risk. Children with metabolic risk had significantly restricted large joint and spine mobility. The blue error bars represent right-sided range of motion, while pink error bars represent left-sided. On performing binomial logistic regression, children in their early puberty with short stature, dyslipidemia, and microalbuminuria had higher risk of development of limited joint mobility. Later in the puberty, long-term disease, poor glycemic control, high insulin requirement had higher risk of developing LGM. The graph here is showing odds ratio of development of limited joint mobility. Blue error bars represent children in early puberty, while pink error bars represent children in their late puberty. Short children, irrespective of the pubertal status, had higher odds of LGM. Recent onset puberty with vascular complications had higher odds of development of LGM. And later in the puberty, metabolic risk had higher risk of development of limited joint mobility. To summarize, 1/5 of children with type 1 diabetes were identified with LGM using Rosenblum's staging criteria. This prevalence was almost doubled with the help of goniometer as compared with traditional prayer sign or tabletop sign. The small joints and lateral flexion of spine were significantly restricted in children with diabetes as compared to healthy peers. Early in the puberty, the risk of LGM was higher with vascular complication, while later in the puberty, long-term disease, poor glycemic control, high insulin requirement, and metabolic risk had higher risk of development of LGM. This was the first Indian study to include comprehensive assessment with goniometer for LGM prevalence, and we assessed not only the small joints of hand but also large joint and spine mobility were assessed. However, our study cohort had poor glycemic control, and more multicentric longitudinal studies are required to understand the pattern of LGM. The role of physiotherapy needs to be evaluated. In conclusion, limited joint mobility is frequently observed in individuals with diabetes, and the presence of a positive prayer sign reveals just a small part of the broader issue of LGM. Growth failure in children with diabetes is associated with LGM independent of pubertal status. Modifiable risk factors later in the puberty are glycemic control and central adiposity to prevent restriction of joint mobility, including spine. Thank you.
I have a very nice presentation. It was good. And something new I learned, goniometer. And so I just want to know one thing. In early puberty and late puberty, what was the duration of the diabetes, which was, in both the cases, because it'd be more in the late puberty as compared to early puberty? You had mentioned that. So does it make a difference in that also? The reason for why you get different presentation in late puberty, more of that involvement in the late puberty and early? Who are the patients who got more LGM as compared early puberty or late puberty?
The
diabetics who got early puberty versus diabetics who got late puberty, who got more LGM?
Later in the puberty, of course, because of the disease duration also, they were affected with the limited joint mobility more in comparison with early puberty. But those children who were early in the puberty and were short had higher prevalence of LGM as compared to children with normal stature.
So how do you explain this?
The growth failure is associated with limited joint mobility, which is reported in literature, and it is a known fact.
So was it confounded by the glycemic control, or after correcting for glycemic control also? So short had a bad glycemic control and they had LGM. If you corrected for glycemic control, still that association was significant?
I think it is a long-term glycemic control, and to understand this pattern, we need longitudinal studies.
Yes. Does it depend upon the duration of the disease, on controlled disease, or on the stage of puberty?
Both.
Both the things.
Both.
Like it's like a retinopathy sort of a thing. So longer you have, worse you have, you will have more.
Thank you.
Thank you so much.
Thank you, the chairpersons. I request Dr. Bhanu to please felicitate the chairpersons and thank you, Dr. Bhanu. Now we break for tea, and at 4 p.m. we will have the session in the main hall. Thank you all.